This, let's start. We have 42-year-old woman is brought to emergency department due to severe headache. 3 hours ago, the patient suddenly began experiencing bilateral headache, which rapidly worsened in severity. She also has had neck pain and an episode of vomiting. The patient has had no prior headaches, and medical history is significant for hypertension. She works in a daycare. Temperature a little bit high, blood pressure a little bit high, pulse good, oxygen good. On physical, we see the patient appears in obvious discomfort and keeps her eyes closed. She follows simple instructions and there is no focal weakness or numbness. When you see like this, so this is not stroke, okay? With no focal, so no stroke. Fundoscopy, no papilloedema. There is increased resistance to passive neck flexion. This is a sign of meningeal irritation. It could be meningitis, or it could be from meningeal irritation like hemorrhage. And it also elicites pain. So, what is the next step? We'll see severe headaches 3 hours ago, suddenly. Okay, the worst headaches we can see it. This is a sign of subarachnoid hemorrhage that goes this passive neck flexion and elicites pain. So what we should do for that? Just do the CT scan of the brain. Okay, it's not lumbar puncture. No, the more specific is CT scan of the brain. So we have subarachnoid hemorrhage. We have results from saccular aneurysm. It could sudden onset, severe headaches, vomiting, neck pain, fever, etc. So, what is the next step? Non-contrast CT of the brain. Okay. If CT scan is unremarkable and still reasonable suspicion for SAH, now we can do lumbar puncture. Okay, to evaluate the red blood cells or xanthochromia. What is xanthochromia? It is a pink or yellow tint of the cerebral or CSF because of hemoglobin deterioration products, by meaning bilirubin. We see bilirubin in the CSF fluids, that's meaning there was RBC. Okay? But it's need as soon as 2 hours following the subarachnoid and persists for weeks. Okay, so this is very good. No need to other choices. No oxygen, no X-ray, no etc. No LP. Sorry, the more sensitive is CT scan, and also for not somatotryptan. This is not migraine. Okay. So we have 27-year-old woman is brought to the emergency department with severe epigastric pain, nausea, vomiting. The pain radiates to her back. This is very important idea that epigastric pain, nausea, vomiting, pain to the back. This is pancreatitis. Okay, don't forget it. And is exacerbated by eating. The patient was recently diagnosed functional bilateral sphincter of Oddi, for which she underwent an ERCP and sphenectomy 24 hours ago. She has no other problems, no alcohol, temperature high, blood pressure good, pulse good, respiration good, no scleral icterus, cardiopulmonary examination good, abdomen is tender, in the epigastrum soft without rebound on guarding. Which of the following is appropriate next step in management of these patients? Okay, the right answer is choice E, serum lipase, for diagnose the pancreatitis. But the most important thing that the pancreatitis happens because of ERCP. Okay, so ERCP and high calcium, high fatty acids or triglycerides all cause pancreatitis. Okay, don't forget this important information. So we have here ERCP is minimally invasive endoscopic technique used to visualize and intervene upon the biliary and pancreatic ducts. But in the first line, post ERCP complications can occur. Post procedural abdominal pain is relatively common, but it could be from infection, okay, by meaning perforation, cholangitis, pancreatitis. So the most common is pancreatitis. This is pain radiates to back. We can see two from this criteria: severe epigastric pain radiating to the back, amylase or LPAS 3 times the upper limit of normal, or characteristic findings of acute pancreatitis on imaging, CT, MRI, ultrasound, etc. Okay, so this is several hours after these enzymes rise within several hours, but CT may remain normal for 48 hours. So don't do CT when you have a few hours of pain or something related to pancreatitis. No, just do the enzymes. Uh, it is because the CT non-specific, it could be normal to 48 hours. No need to MRCP, HIDA, CT scan. Okay, we talk about it. The right answer is LIPAS. What about AAA? What is AAA? This is abdominal aortic aneurysm. Okay, the symptoms suggesting unstable AAA. We see this in abdominal or flank or groin pain. Pulsatile mass. The important one of aneurysm is this pulsatile mass. We can see flank ecchymosis or limb ischemia. Looking for hemodynamic, if stable or unstable. If it is instability, okay, look for previous AA. If you know that you have AAA previously, don't do anything, just surgical or emergency repair. By meaning, you know, this person had AAA, but all the time was stable. But now have hemodynamically instability, so just emergency repair. If no AAA, we can do what we call fast ultrasound or focused abdominal ultrasound to look for the AAA. If you see it, emergency repair. No see it, explore other diagnosis. So if it is unstable, do fast ultrasound. If it is stable, do CT of abdomen. Okay? If you see it, the AAA, maybe we can do medical optimization and repair, not emergency repair, because he is stable. No stable, no, sorry, no AAA, so explore other diagnosis. So this is the table or approach for AAA. The most important thing that hemodynamically instability or stability. Instability, and you know it, do the surgical repair. No, if it is stable, everything good, maybe we can do medical optimization and repair. Okay, this is a very important one. Another surgical problem, what we called fat embolism syndrome. This is fracture of marrow-containing bone like femur, or orthopedic surgery, or pancreatitis. Be careful from that. Pancreatitis could cause fat embolism. We will see it the 24 or to 72 hours following the inciting event. We will see clinical triad, respiratory distress, neurologic dysfunction, and petechial rash. Don't forget these three things. To diagnose, just clinical. The prevention and treatment, early immobilization of fracture. When you see it, please stabilize that, or make leg bag, etc. Just make it immobilization. And for sure, supportive care. If you see respiratory distress, etc., do the ventilation And that, just to remind you, 24 to 72 hours following a fracture. Okay? So if you have any concerns, just let me know. Let's see if there's anything. Okay. Okay. So we have here a 38-year-old woman comes to the office due to increasing episodes of nausea and substernal discomfort over the past several months. The episode frequently occur after eating, and the patient occasionally self-induces vomiting to relieve the symptoms. This is very bad, and this self-inducing vomiting that could related to anorexia bulimia, okay, and that could cause parotiditis, okay, the gland, okay, the parotid could be higher than previous. Don't forget this important idea. Self-induced vomiting could cause parotid hypertrophy. 2 weeks ago, in addition to problem in tooth, okay, 2 weeks ago she also had difficulty swallowing while experiencing a sensation of food getting stuck in her chest. She has no anorexia, weight loss, hematemesis or melena, no bleeding, no problem, no ulcers, no at all. The patient had GERD during pregnancy 10 years ago, but no other problem. She takes no medication, no cigarettes, drinks alcohol occasionally, vital signs good, BMI good. We see normal oropharynx, non-tender abdomen, but in chest imaging we see retrocardiac air fluid level. When you see air fluid level retrocardiac, by meaning we have the stomach in the chest. Okay? This is air fluid comes from. Which of the following the underlying cause? It is degeneration of esophageal ganglion cells. No. This is could be chalasia. Esophageal metaplastic and dysplastic change. No. It could be DAS or cancer, etc., but not this fluid. The right answer is gastric herniation into the thoracic cavity. Okay? So just to remind you, this is very rare case, but we can see it. This is hiatal hernia. It's more common in infants, but could happen on old age. We have the normal one, GE junction, below the diagram. We see sliding hernia, just the herniated gastric cardia, but in paraesophageal hernia, we'll see the herniated gastric fundus in the chest. Okay? So obviously we have this paraesophageal hiatal hernia. Okay? Because of retrocardiac air fluid level. Okay, just like that. An important case, very important case, we have here what you called a 28-year-old man comes to the emergency department due to respiratory distress. A week ago, he developed a sore throat that has progressively worsened. Over the last hour, he has had difficulty breathing. The patient was diagnosed with HIV at age 23 and has been inconsistent with daily therapy. He have high temperature, pulse is high because of temperature, respiration high, pulse oximetry very low. The patient is leaning forward with his neck extended, he's drooling, speaking in a hoarse voice, posterior oropharynx overlying white plaques. This is for because of candida of HIV. We are suprasternal retraction because of this low oxygen. Examination reveals diminished breath sounds bilaterally, by meaning air doesn't go down. Pulse remains with oxygen high. So we do the E-tube or endotracheal intubation. Using video is attempted, but it is unsuccessful. We still have the low oxygen. So what we should do? Okay, this is HIV. Okay, with this drawling and stutter and hoarse voice, sorry, not stutter, hoarse voice and drawling, and his neck extended. This is triad extended or trizome, by meaning on his both of hands and open his mouth. So this is epiglottitis. Why it's happened here, not in pediatric? Because we have HIV. Okay, so it could see this problem. This is Haemophilus influenza cause, but here we need a surgical treatment. What we should give, because we have the unsuccessful endotracheal intubation, so just do perform a surgical cryothyrectomy. Okay, this is the so you can open below the laryngeal edema or laryngeal spasm, etc. Maybe we can do this surgical cryothyrectomy when anaphylaxis. Okay, when you have edema in laryngeal edema, we can do this surgical cryothyrectomy. Okay, so we have epiglottitis, airway deterioration, and airway management is the main priority. So the back valve ventilation don't give the right advocate oxygenation, so we can do endotracheal intubation using video. If still no fix, now move to surgical cryothyrectomy. Okay, this is very important idea. No mask, no PP, no several attempts, no blind nasotracheal intubation. No, just do this surgical cryothyrectomy. Okay, let's see if you have any concerns. Please, if you have anything unobvious, just let me know. How to differentiate subarachnoid and meningitis clinically. One, fever. Second, the headache in meningitis comes in gradual onset, but in subarachnoid we have suddenly. About the let me see the sorry, the hypertension. Okay, if you have hypertension or history of hypertension, so subarachnoid hemorrhage is more obvious than meningitis. Okay, the most important thing, the gradual in meningitis and suddenly in subarachnoid. Okay, uh, maybe Kering and Prodensky, we can see it in both of them, because we have here in irritation, okay, meningeal irritation. So we can see it in both of them, okay? So don't depend on them. Even the pharyngeal or retropharyngeal abscess could cause this Kering, Prodensky, and the stiffness, okay? I wish your answer is clear now. Okay, so uh, we have the patellar dislocation. The risk factor is joint laxity, misaligned lower extremity or tight band, patellar subluxation, or competitive sports dance medullary training. How we will see this patellar dislocation? Quick twisting motion around the flexed knee. You see this, something is mobile. Feeling a knee giving away, pain, popping noise. Okay? In examination, we'll see the lateral dislocation of patella, decreased extension. So what we should do, the third paragraph, patellar dislocation often reduces spontaneously. However, closed reduction is required for patient without spontaneous resolution with follow-up splinting, rehabilitation for muscle strengthening. Okay, but the most often is spontaneously. Okay, so we have Baker cyst, Baker cyst or papilloteal cyst. This is extrusion of a fluid from knee joint space into semimembranous or gastrocnemius bursa. This is part of this muscle. Just we have this fluid goes out from the knee joint space. We'll see it after trauma, especially meniscal tear, underlying joint disease like OA or RA. What we will see, we'll see a symptomatic bulge behind knee that diminishes with flexion. Do the flex? No, cyst. Okay? We have a posterior knee pain, swelling, stiffness. So, what about complication? Because of this cyst, it could cause venous compression, could dissection into a calf, okay, by meaning edema, erythema, etc. It could rupture, could cause pain, warmth, erythema, or ecchymosis. So, just treated by inspiration, okay? About thoracic aortic injury, the most important thing we will see widened mediastinum, okay, and enlarged aortic knob. You see this knob? This has come from aortic. Here we see it very high. This is especially when you see fall then higher than 3 meter or rapid declarations landing on pavement. This is blunt thoracic aortic injury. Okay, this is very important idea. If you do the CT, we will see, or sorry, X-ray, we will see this widened mediastinum. Okay, here the blunt thoracic aortic injury, we can see it after the declaration, acute declaration. We'll see it from mobile ascending aorta. That could cause three things or four things. It could be incomplete or complete rupture or pseudo coarctation aortic, by meaning the normal one, but because of blood, that could cause pseudo coarctation, or just tear, intimal, or media that could cause uh, problem in the aortic. Okay, all of that comes from blunt thoracic aortic injury. Okay, what about hemorrhoids? Very important question in the exams. We'll see it how to dietary factors for for management, increase fluid intake, increase fiber, like foods or fiber supplements, reduced fat, and moderation of alcohol intake. The hemorrhoids goes bad with alcohol. About behavioral factors, limit time sitting on toilet, just 3 minutes, not higher than that. Limit defecation to once daily. Avoid straining. Maybe we can give benzocaine or astringents, I mean witch hazel, just emulates and hydrocortisone. Okay, this is for hemorrhoids. What about dumping syndrome? A very important case. We'll see it abdominal pain, diarrhea, nausea, hypotension, tachycardia, dizziness, confusion, fatigue, or diaphoresis. Wow. When we'll see that 15 to 30 minutes after meals because of rapid emptying of hypertonic gastric continence. That will cause a lot of fluids come from the body into the intestine. That will cause hypotension, and this hypotension could cause dizziness and confusion and fatigue and diaphoresis. And by the contrast, we'll see tachycardia to try to hypertension. Okay? In addition to that, we'll see abdominal pain, diarrhea, nausea. The most important thing, we have small frequent meals, replace simple sugars with complex, and incorporate high fiber and protein-rich foods. Okay? This is the management for dumping syndrome. Okay? Easy one, but important. What about suspected gastrinoma? How we'll see this gastrinoma? If you do endoscopy, you could see multiple stomach ulcers and thickened in gastric folds. So, what we'll see it? This is what we should do. Do the gastrin level, but we should stop PPI for 1 week before. Not every day take PPI and look for gastrin. No, we should stop gastrin for 1 week. Sorry, stop PPI for 1 week and do the gastrin. If it is low, so no gastrinoma. It is high, check for gastric pH. Okay. If it is higher than 4, also this is not gastrinoma, by meaning this is the basidic. Okay, or more basic, higher than 4. If it is no high gastrinoma, low pH, so this is gastrinoma. Look for that. What about secretin stimulation? The secretin stimulation, the normal one, the gastrin will be low. Okay, this is if we see the range between thousands and 110. You see this is in the gray zone. Let's we talk about it. So do creatine. If it is positive, by meaning the gastrin is still high, so this is gastrinoma. No, low in gastrin, so this is not gastrinoma. Okay, this is the about the approach for gastrinoma. Okay, just let me see if there's anything you need. Okay, so we have here an 88-year-old man is evaluated due to severe right calf pain several hours after undergoing a right femoral artery embolectomy. Okay, after that we see the right calf pain. He also has burning sensation in the posterior aspect of the right leg. The patient has persistent AF and hypertension. His medical history includes we have ischemic stroke, bleeding ulcer, type 2 diabetes mellitus, diabetic nephropathy, no hypertension, sorry, no blood, no temperature, blood pressure a little bit high, pulse good, but irregular. Okay, by meaning we have something in ECG. The right calf is swollen, tense, and tender, with pain is worse with passive dorsiflexion of the ankle. You see this? This is the diagnostic test. In addition to memorize this, the skin is shiny, cool to touch, sensation over the leg decreased, and the patient is unable to move his toes. We see the dorsalis pedis and posterior pulses palpable. Which of the following most likely cause? When you see problem, the pain is high with passive dorsiflexion. After surgical on this extremity, so this is complement syndrome. Okay, always be careful from that. It's not vaso-occlusive because with the pulse is good, not venous thrombosis, because in venous thrombosis the sense is clear, normal, no problem at all. No necrotizing fasciitis because we don't have fever. No embolism, okay, because the pulse is good. So this is complement syndrome. We have pain out of proportion to injury, meaning a little bit injury, but the pain is very high. Pain on passive, rapidly increase the swelling, and paresthesia early. The first since we lose it is the sense, okay, or paresthesia, sorry, the tingling. So we have low sensation, low motor, paralysis, distal pulses, uncommon. Okay, the last one gets happen or could happen is the loss of pulses. So this is ischemia reparation syndrome. Okay, that could cause or form of complement syndrome. This is limb-threatening condition because of enclosed fascial space that limits perfusion of muscle and nerve tissue. It is most common following traumatic or compression of extremities after reperfusion, like we see in this patient. We have urgent fasciectomy because we see delta pressure, by meaning the diastolic blood pressure will be lower than 30. So this is problem. No need to know this pathology, but the important one is urgent fasciectomy. No other problems. We talk about them all. Okay, about steatorrhea. If you see steatorrhea, what we should do or what we should look for. The common causes of steatorrhea, the pancreatic insufficiency, by meaning chronic pancreatitis or pancreatic cancer, or bile salt related like small bowel Crohn disease, bacterial overgrowth, primary biliary cirrhosis, primary sclerosing cholangitis, or surgical resection of ileum, impaired intestinal like celiac, AIDS, giardia, or other rare cause like Whipple, Zollinger Ellison, and medication induced. Okay, just like that, we covered very good content of surgery.